All right, let's move on to our next presentation, which is from Dr. Megan Wallace, and it is updates to immunity and epidemiology to inform COVID-19.
Thank you. Good afternoon. Next slide, please. First, I'll present a brief update to the overall U.S. COVID-19 epidemiology. Then I will present data on COVID-19 post-infection immunity and COVID-19 reinfection. Finally, I will present data on the epidemiology of COVID-19 in pregnant women. Next slide. Next slide, please. As of October 29th, over 8.8 million COVID-19 cases have been reported to CDC. This map shows the cumulative case counts by county, with the darker red representing larger numbers of cases. Next slide. This figure shows the trends in the number of COVID-19 cases reported per day in the U.S., with the 7-day moving average in red. Nationally, cases peaked first in early April and again in mid-July, and after a several-week decrease have been increasing over the past 6 weeks, surpassing the previous peak in July. Next slide. This figure shows the trends in COVID-19 cases per 100,000 population by urban-rural classification. During the first two COVID-19 incidence peaks in spring and summer, the highest COVID-19 incidence rates were in large metropolitan areas. Since mid-August, this trend has shifted, and currently, more rural, small, and non-core metropolitan areas have the highest incidence rates. Next slide. This graph shows the number of specimens tested and percent positive for SARS-CoV-2 for public health laboratories and a subset of commercial and clinical laboratories. The number of specimens tested are in the bar graphs, and the percent positives are shown in the line graphs. Nationally, the percentage of specimens testing positive for SARS-CoV-2 was 6.3% for this past week, which is a slight increase compared to the previous week, in which 5.6% of specimens tested were positive. Next slide. This figure shows the weekly COVID-19 associated hospitalization rates by age group from the COVID-19 associated Hospitalization Surveillance Network, or COVIDNet. COVIDNet conducts population-based surveillance for laboratory-confirmed COVID-19 associated hospitalizations in select counties participating in the Emerging Infections Program and the Influenza Hospitalization Surveillance Project. Overall, weekly hospitalization rates among all ages combined first peaked during the week ending April 18th, or MMWR week 16, followed by a second peak during the week ending July 18th, or MMWR week 29. Since the week ending September 26th, or MMWR week 39, overall weekly hospitalization rates have increased for all ages combined, driven primarily by an increase in rates among adults aged 50 years and older. Data for the most recent weeks may change as additional admissions occurring during those weeks are reported. Next slide. As of October 29th, a total of 227,045 deaths due to COVID-19 have been reported to CDC. This map shows the cumulative number of deaths by county, with the darker purple representing larger numbers of deaths. Next slide. This figure shows the trends in the number of COVID-19 deaths reported per day in the U.S., with the 7-day moving average in red. Nationally, deaths peaked first in mid-April and again in early August, and after a slight decrease have plateaued over the past month. Next slide. This figure shows the trends in pneumonia, influenza, and COVID-19 mortality. The National Center for Health Statistics collects death certificate data from vital statistics offices for all deaths occurring in the United States. Based on death certificate data available as of October 22nd, the percentage of deaths attributed to pneumonia, influenza, or COVID-19 for the week ending October 17th is 7.6%. And while lower than the percentage for the previous week, it remains above the epidemic threshold and will likely increase as more death certificates are processed. Next slide. Next, I will present on COVID-19 post-infection immunity. First, we will explore what happens to anti-SARS-CoV-2 antibodies after infection. Next slide. This figure is from an animal study in which 9 rhesus macaques were inoculated with SARS-CoV-2 at 3 different doses. All 9 macaques challenged with SARS-CoV-2 developed binding and neutralizing antibody responses by day 35 post-challenge. At day 35, 2 macaques from the high and medium dose groups had lower neutralizing titers than at 14 days. Next slide. The same 9 rhesus macaques were re-challenged on day 35 after the initial viral infection with the same doses of SARS-CoV-2 that were used for the primary infection. After re-challenge, nasal swab viral RNA was lower than during the first challenge, but still detectable. Re-challenge of rhesus macaques boosted antibody responses, including increased virus-specific ELISA titers, pseudovirus neutralization titers, and live virus neutralization titers. In this animal model, there is evidence that anti-SARS-CoV-2 antibody develops after infection and can be boosted, but it is less certain if this occurs in humans. Next slide. This figure is from a study of 37 asymptomatic individuals and 37 symptomatic individuals with RT-PCR confirmed SARS-CoV-2 that were hospitalized for isolation purposes. In this group, SARS-CoV-2 antibodies decline between the acute phase and 2 months post-discharge. The virus-specific IgG levels in the asymptomatic group were significantly lower relative to the symptomatic group in the acute phase. 93% of asymptomatic individuals and 97% of symptomatic individuals had a reduction in IgG 2 months post-discharge. 81% of asymptomatic individuals and 62% of symptomatic individuals had a reduction in neutralizing antibody levels 2 months post-discharge. 40% of asymptomatic individuals became seronegative, and 12.9% of symptomatic individuals became seronegative in this early convalescent phase. Next slide. In healthcare workers with a history of mild SARS-CoV-2 infection, serum antibodies waned 2 months post-infection. These figures show 8 healthcare sites with levels of anti-spike serum pan-Ig antibodies dropping from baseline to 2 months post-infection. Next slide. An additional study measured antibody responses to the receptor binding domain of the spike protein of SARS-CoV-2 in 343 North American patients infected with SARS-CoV-2, of which 93% required hospitalization. IgG responses were maintained in this group, with only 4% seroreversion within 90 days. Researchers also measured pseudoneutralizing antibodies targeting the SARS-CoV-2 spike protein in 88 samples from 15 individuals collected between 0 and 75 days post-symptoms. Over the course of infection, all individuals developed detectable neutralizing antibodies. As shown in this figure, neutralizing antibody titers demonstrated little or no decrease over 75 days since symptom onset and were strongly correlated with IgG antibodies to SARS-CoV-2 receptor binding domain. Next slide. Next, we will explore if persons infected with SARS-CoV-2 mount cellular immune responses. Next slide. In a study that measured SARS-CoV-2 memory B cells and serum antibodies by days following onset of symptoms, memory B cells did not wane at the same rate as serum antibodies. To evaluate the persistence of anti-receptor binding domain antibodies following COVID-19 recovery, the antibody levels were tested for their association with days following onset of symptoms. Researchers found that the antibody levels were inversely correlated with the days following symptom onset. Follow-up samples were collected from 6 recovered patients approximately 2 to 3 months following the previous blood draw time point and revealed a significant drop in antibody levels reaching to the basal levels found in the control group. In contrast, receptor binding domain specific memory B cells were stable over time. Follow-up samples from a subset demonstrated similar persistence of memory B cells. Next slide. Recovered COVID-19 patients also have SARS-CoV-2 specific CD4 T cells and CD8 T cells. In this study comparing 10 COVID-19 cases and 11 SARS-CoV-2 unexposed controls, SARS-CoV-2 spike-specific CD4 T cell responses were detected in 100% of COVID-19 cases. Non-spike-specific CD4 T cell responses were also detected in 100% of COVID-19 cases. CD8 T cell responses were seen in 70% of COVID-19 cases. Next slide. In conclusion, repeat exposure to SARS-CoV-2 may cause boosting of immune response. Several studies have observed waning of serum antibodies in COVID-19 patients after a few months. This waning of antibodies is expected, but implications for protection are unknown. Neutralizing antibody titers demonstrated little or no decrease at 75 days post-symptom onset. SARS-CoV-2 specific cellular B and T cell responses were detected in COVID-19 patients, and memory B cells did not decay as fast as serum antibody titers. Next slide. Now we will move to COVID-19 reinfection. Next slide. COVID-19 reinfection is infection with SARS-CoV-2 following recovery from previously documented SARS-CoV-2 infection. Reinfections occur with other human coronaviruses and become more common over time, likely as a function of both waning immunity and increased exposure. Next slide. This was demonstrated by a study that investigated reinfection with HCoV-229E, which is a seasonal coronavirus. In this study, 15 volunteers were inoculated with the virus. 10 had subsequent live viral shedding, of which 8 had clinical colds. 1 year later, 6 of 9 previously infected volunteers were reinfected on repeat challenge. However, all were asymptomatic, and the period of viral shedding was shorter than before. Next slide. Among the infected volunteers in this study, antibody concentration started to increase 1 week after inoculation and reached a maximum about 2 weeks after inoculation. Thereafter, antibody titers slowly declined. Next slide. In an additional study, 10 adult male volunteers had blood drawn every 3 to 6 months for more than 10 years between 1985 and 2020. Antibodies against the 4 seasonal coronaviruses were measured. A greater than 1.4-fold change in antibody optical density was considered an infection event. Next slide. A total of 101 coronavirus infections were identified, ranging from 3 to 17 infections per individual. The number of infections per individual from a single species of coronavirus ranged from 1 to 12. The reinfection times ranged between 6 and 105 months. Next slide. Based on this current evidence for SARS-CoV-2, reinfections are likely uncommon within 3 months. Next slide. To date, the strongest evidence for SARS-CoV-2 reinfection comes from a report of reinfection in a 33-year-old living in Hong Kong with no pre-existing conditions. On March 23rd, he developed a productive cough, sore throat, fever, and headache. On March 26th, he had a positive SARS-CoV-2 RT-PCR test result. He was hospitalized per policy on March 29th, but with improving symptoms. On April 2nd, or day 10 of his illness, he tested IgG negative. By April 14th, he had his second negative RT-PCR test and was discharged from the hospital and returned to normal activities. In August, he took a vacation to London and Spain. When he returned to Hong Kong on August 15th, he again tested positive for SARS-CoV-2 by RT-PCR upon entry screening. On August 16th, he again tested Ig negative, but had a positive IgG test result on August 20th. Next slide. The Hong Kong case demonstrates evidence for acute substantial infection as well as substantial genomic differences of 23 nucleotides. A case from Belgium offers intermediate evidence of reinfection with positive results 93 days apart and a genomic difference of 11 nucleotides. An additional case from Nevada offers a lesser degree of evidence with positive test results 43 days apart in which the second illness course was worse than the first. Distinct viral genomes were demonstrated, but there was not a significant viral burden in the second course of illness. In a study of results from migrant workers in Qatar, investigators searched for repeat positive RT-PCR results greater than 45 days apart among 133,000 cases. 35 or 0.03% of which had CT values less than 30 on the second specimen. In a CDC reinfection investigation of individuals with recurrent COVID-19 symptoms with positive SARS-CoV-2 PCR but no alternate etiology identified for their symptoms, 26 cases had specimens available for both illness episodes. All specimens from the second episode of infection had CT values greater than 30 and no replication-competent virus isolated. Most commonly, reports of reinfections consist of patients who became PCR positive for SARS-CoV-2 after recovery, but no further workup is available. Next slide. In conclusion, reinfections occur with other human coronaviruses and become more common over time. Reinfection for SARS-CoV-2 is possible, but likely uncommon within the first 3 months. Next slide. Now I will present data on the epidemiology of COVID-19 in pregnant women. Next slide. In the past several meetings, ACIP has discussed who should be in the initial allocation phases for vaccination. There has been agreement for phase 1A to be healthcare personnel. Next slide. 75% of the healthcare workforce are women, and women are a majority among the largest healthcare personnel groups, including 88% of registered nurses and 86% of healthcare support workers. Next slide. Therefore, we expect there could be around 330,000 healthcare personnel that are pregnant or recently postpartum when initial vaccine recommendations are made. While ACIP has not yet discussed vaccination of pregnant women, we want to present data to inform the discussion around what recommendations might be made for pregnant women who fall into those initial allocation groups, including healthcare personnel. Next slide. Now I will present data on the risks of COVID-19 during pregnancy. Next slide. In a systematic review and meta-analysis on COVID-19 in pregnancy, we see that pregnant women with COVID-19 have an increased odds of ICU admission compared with non-pregnant women of reproductive age. Next slide. This meta-analysis also demonstrated that pregnant women with COVID-19 have an increased odds of invasive ventilation compared with non-pregnant women of reproductive age. Next slide. In this analysis, pregnant women have no increased odds of death compared with non-pregnant women of reproductive age. The overall number of deaths were low, and this was a rare outcome. Next slide. Preliminary and unpublished U.S. data can add to the evidence base. Next, I'll present preliminary findings of an update to this previously published MMWR on the characteristics of women of reproductive age with laboratory-confirmed SARS-CoV-2 infection by pregnancy status. Next slide. This analysis included case surveillance data for women aged 15 to 44 years with laboratory-confirmed SARS-CoV-2 infection reported to CDC during January 22nd to October 3rd. The data include over 30,000 pregnant women, which is a sample size 5 times larger than the previous report with more complete data. These data were updated in the last 24 hours, and although the results differ slightly than those previously shared, the interpretations haven't changed. Next slide. In these data, there were 274 ICU admissions, 88 mechanical ventilations, 17 ECMO, and 45 deaths among pregnant women. Next slide. After adjusting for age, race, ethnicity, and presence of underlying conditions, pregnant women had a higher relative risk of ICU admission, mechanical ventilation, ECMO, and death compared to non-pregnant women. The relative risk for each of these outcomes are higher than estimated in the previously published MMWR. The receipt of ECMO was not assessed in the last report due to small numbers. Next slide. The previously discussed systematic review and meta-analysis also looked at birth outcomes and found that neonates of mothers with COVID-19 are at increased risk for preterm birth before 37 weeks compared to those without COVID-19. Next slide. Although samples of breast milk have tested positive by RT-PCR, current evidence suggests it is not a likely route of transmission. Rate of infection is no greater when a baby is breastfed or remains with the mother. Breast milk is still the optimal source of nutrition for most infants, even those born to mothers with suspected or confirmed COVID-19. Precautions to avoid spreading the virus to her infant should be taken. Next slide. In conclusion, we expect around 330,000 healthcare personnel to be pregnant or recently postpartum at the time a vaccine becomes available. Data demonstrate increased risk of severe maternal illness and preterm birth due to COVID-19, though these outcomes are infrequent. Although samples of breast milk have tested positive by RT-PCR, current evidence suggests it is not likely a route of transmission and breastfeeding is still recommended. Next slide. Next slide, please. In summary, as of October 29th, over 8.8 million cases of COVID-19 diagnosed and over 227,000 COVID-19 associated deaths have been reported in the United States. Data on post-infection immunity are limited, but suggest that antibodies wane over time. SARS-CoV-2 cellular immunity has been detected in COVID-19 patients. Reinfection data are limited, but suggest that reinfection is unlikely within 3 months of infection. Pregnancy data demonstrate increased risk of severe maternal illness and preterm birth. Next slide. Finally, I would like to acknowledge all the individuals that contributed to this presentation. Next slide. Thank you.
Thank you for that excellent summary. We're open for questions, voting members and liaisons. I think we're all tired. Dr. Eckert, please. Oh, here we go. Dr. Eckert, go forward.
Thank you. Hi, I am representing ACOG as the liaison, and we just want to stress that we feel that women who are pregnant and are lactating should not be excluded from what are identified as high priority populations for a COVID-19 vaccine allocation strategy. So in addition to being identified as an at-risk group by themselves, like we just saw in this excellent presentation, and hearing that upwards of half of pregnant women also fall into another priority category, including the frontline workers and those with underlying conditions. Additionally, as we just heard, women make up more than 75% of the healthcare workforce, and it's estimated that 330,000 pregnant healthcare workers are in the workforce. As such, ACOG urges ACIP to incorporate pregnant and lactating women clearly and explicitly into its COVID-19 vaccine allocation and prioritization framework. And should an emergency use authorization be executed for one or more COVID-19 vaccines and provide a permissive recommendation for pregnant and lactating women, pregnant healthcare workers, pregnant first responders, and pregnant individuals with underlying conditions should be prioritized for vaccination alongside their non-pregnant peers. Thank you for the opportunity to submit comments and inform the critical work of your committee, and we really appreciate all that you are doing.
Thank you very much, Dr. Zahn.
Thanks. Can you hear me?
Yes, we can.
Okay. Yeah, thank you all for these presentations. Regarding the reinfection issue, just as a local public health person, I'd say that when you've had a large surge in your community afterwards, it's not tremendously uncommon to have people remain PCR positive more than 3 months after infection. And for all of those events, when they're identified, you have to act on it and do something about it. And obviously, you can try and culture to find the virus, but or genotype if you happen to have both specimens. But for both of those lab results, it takes a while to come back, so you kind of have to act on what you have. And it seems like reinfection is uncommon. But for every time you kind of have to come up with a plan. What are you going to do? If someone's hospitalized, do they need to be in isolation? If they're in a congregate living setting, do you need to initiate an investigation? If they're at home, do you need to isolate them and quarantine their family? And it's a lot of questions. And I would just comment that I think locally a lot of us are sort of coming up with standards of practice that we do based on the best information we have, because it's really just burdensome to act as if all of these are new positives. So I appreciate CDC's initial guidance regarding 90 days and less and symptomatic, and so I appreciate that initial guidance. But obviously you can only tell us what you know from the information you have. But I just say that the sooner that the CDC, you have some confidence level on what you can say about how to respond to these potential reinfection events, that would be very appreciated from a local level. Thanks.
Thank you for those comments. Dr. Kimberlin.
It's David Kimberlin, AAP Redbook. I'd like to echo what Dr. Zahn just said. My only comment, and this is a phenomenal summary of what we know, and by inference, what we don't know about reinfection. It does seem to me that the language utilized is perhaps stronger than I would be comfortable with. Likely uncommon within 3 months. It sounds like, to me anyway, that we know more about it than I would suggest we really do. I would be more comfortable with language such as appears to be uncommon, may not be common. I mean, something with a little bit more wiggle room, and then it still opens up all the challenges for management that Dr. Zahn touched on.
Thank you for those comments. Just a reminder, we want to keep our comments limited towards the issue of the vaccine. I understand that reinfection is a very hot topic and hot button topic, and I live it with you all, but let's focus on the vaccine. Thank you again for your comments. Dr. Maldonado.
Yeah, thank you, Bonnie Maldonado, AAP. Not to belabor this point, but I do think with respect to the vaccine, I think the messaging, and again, we don't know what the final messaging will look like, but I do think that the messaging around vaccine is not, I'm now not going to be infected in the next 3 months. I think the question around the vaccine is, we know that vaccines are imperfect, that efficacy is not going to be 100%. And so I think the issue of vaccine plus existing mitigation needs to be emphasized, and not just, a vaccine and lack of reinfection. So I think Dr. Zahn really spoke to that at a public health level, but I think the messaging needs to be very, very focused, that the vaccine is not a panacea for immediate full herd immunity. And we need, it's one piece. It's the PI part of, in addition to the NPI.
Thank you for those comments, Dr. Maldonado. And Dr. Oliver will comment on this under her presentation work group interpretation of the data. Dr. Lee.
Thank you so much for the excellent presentation. I'm wondering out loud if when the data feel like it's ready to be sort of formally evaluated and presented, given the increased risk ratios, whether or not pregnancy itself would be considered a high-risk condition, and that how that might influence our vaccine recommendations.
Thank you. It's being considered by CDC at this time, so there will be some comment coming forward. Thank you. Any other comments or questions? Okay, so let's move on to the next presentation, which will be Ethical Principles of Early Vaccine Allocation by Dr. Mary Chamberlain. Dr. Chamberlain, please.
Thank you. This afternoon, I would like to provide an update on ethical principles for the phased allocation of COVID-19 vaccines. Next slide. ACIP's recommendations for the allocation of COVID-19 vaccine will be guided by science, ethics, and implementation considerations. The ACIP recommendation process for every vaccine uses an evidence to recommendation framework to systematically assess available scientific information about the vaccine's safety, efficacy, and other related factors. Recommendations also take into account the feasibility of implementation, such as cold chain requirements. Next slide. The purpose of the ethical principles is to assist ACIP in the identification of groups for early allocation of COVID-19 vaccine in the setting of a constrained supply. Next slide. ACIP endorsed the following 5 interim ethical principles at its September meeting: maximizing benefits and minimizing harms, equity, justice, fairness, and transparency. Over the course of several meetings, ACIP has also explored possible groups for early phase vaccination. 4 groups for phase 1 vaccination have emerged: healthcare personnel for phase 1A, and under consideration for phase 1B are essential workers other than healthcare personnel, persons with high-risk underlying medical conditions, and adults aged 65 years and older. Next slide. The work group has continued to progress efforts related to the ethical principles. Specifically, it reviewed COVID-19 vaccine allocation frameworks, including those from Johns Hopkins University, the National Academies, and the World Health Organization. The National Academies released a final version of its document in early October, and WHO recently released a new document on prioritizing COVID-19 vaccines in the context of a limited supply. The work group reviewed additional ethical literature whose publication continues apace, continued to consult with experts in health equity, ethics, and grade, updated the interim ethical principles to guide phased allocation, drafted a manuscript on ethical principles, including key questions to guide allocation planning, and work has also begun to incorporate a health equity domain into the evidence to recommendation framework, which Dr. Dooling will cover in her presentation. Next slide. The ACIP work group, after discussion and consultation with experts in ethics and health equity, is proposing 4 ethical principles for phased allocation of COVID-19 vaccines, namely, maximize benefits and minimize harms, promote justice, mitigate health inequities, and promote transparency. In this updated version, the principle of fairness was folded into justice. The two are closely related. In fact, it's difficult to find language defining or describing justice that does not include the word fairness. Joining up the two seemed appropriate in the context of vaccine allocation. The work group also elected to style the ethical principles as action phrases. Although other frameworks for COVID-19 vaccine allocation demonstrate differences in their structure and their emphasis, nearly all reference values and principles similar to the 4 which ACIP considers fundamental. Next slide. A new addition is the development of a series of key questions to facilitate translation of the ethical principles into practice. They were developed with the idea of explicating the principles into something tangible. These questions can assist ACIP in developing its national recommendations for early phase COVID-19 vaccine allocation, and they can also serve as a tool for state, tribal, local, and territorial public health authorities to consider when developing their implementation plans for allocated groups in their jurisdictions. The ACIP work group noted that while ethical principles are fundamental for stewardship of a limited supply of vaccine, they are also applicable when COVID-19 vaccines become more widely available. Next slide. The next 4 slides lay out a series of key questions for each of the ethical principles relevant for vaccine allocation planning. I will highlight a few of these questions on each slide. For maximize benefits and to minimize harms, some questions to consider are: does the allocation plan address what populations are at highest risk from COVID-19? What populations are essential to the response or maintaining critical functions? And finally, what are some of the key characteristics of these populations that need to be considered in the plan? These populations will vary locally. Jurisdictions will have to plan where to focus within a designated allocation group when vaccine supply is limited. These questions align well with the CDC Vaccination Program Playbook section on critical populations. Next slide. With respect to the principle of justice, one would want to consider how to include input from groups who are disproportionately affected by COVID-19, and then ask if the plan results in fair and equitable access for all people in the group allocated to receive vaccine. Answering that question will require identifying and addressing barriers to vaccination and assessing how the characteristics of the vaccine and any associated logistical considerations might impact equitable access. And again, these questions align well with the CDC playbook. Next slide. Some of the questions for mitigation of health inequities overlap in part with the principles of maximize benefits and promote justice. The last question calls for consideration of health inequities that may inadvertently result from the allocation plan and what interventions could remove or reduce them. Next slide. Moving from top to bottom, the key questions for the principle of transparency ask about the development of the allocation plan, particularly the inclusion of diverse input, as well as the availability of the plan to the public. The questions reinforce the importance of being clear about the level of certainty in the available evidence, with a process in place for revision of the allocation plan if new information warrants change. Next slide. The next several slides apply the ethical principles to the 4 populations under consideration for Phase 1 allocation. ACIP, at its September meeting, considered that the transparency principle was more about process rather than individual populations. Transparency is applied across the entirety of the allocation decision-making process. It's essential for building public trust and confidence and maintaining that. It includes being clear about the level of certainty in the available evidence and timely communication of new information that may change recommendations. The ACIP recommendation process is transparent in that both the methods and data used to make recommendations are publicly available. Public participation in the process is facilitated through a variety of mechanisms. ACIP meetings are open to the public and available online. Members of the public can provide comments to the Federal Register and/or in person during the public comment period of ACIP meetings, and engagement with stakeholders and partners is promoted through the inclusion of some 30 non-voting representatives from liaison organizations. Next slide. The next 4 tables illustrate how each of the ethical principles can be applied to the 4 groups under consideration for early vaccine allocation. The tables, which were presented at the September ACIP meeting, have been updated. To simplify the tables, we now include only descriptive text for each principle. Some of the quantitative data has moved to the footnotes. To orient you, the allocation groups appear in the far left column, including a description of the group and the estimated number in the group. For healthcare personnel, this number has been updated from approximately 20 million to 21 million. Information related to 3 of the principles are in the remaining columns. The principle of transparency is displayed along the bottom row to indicate that transparency is to be applied across the entirety of the process. I'll not go through the tables in detail, but we'll highlight some of the changes in particular. Under maximized benefits, in addition to noting that vaccination of healthcare personnel preserves healthcare capacity, which is essential to the response, we include a benefit termed the multiplier effect. Namely, vaccinating a healthcare worker multiplies the benefit of vaccination in that the health of that individual worker also helps to protect the health of others by the worker being able to provide COVID and non-COVID related care. Under justice, vaccination of healthcare personnel addresses the elevated occupational risk of SARS-CoV-2 exposure for those workers unable to work from home and promotes access to vaccine across the entire spectrum of healthcare personnel. Finally, with respect to mitigating health inequities, vaccination would help address the overrepresentation of some racial and ethnic minority groups among low-wage healthcare personnel. Next slide. The number of other essential workers has been updated from approximately 60 million to now 87 million workers. Application of ethical principles to other essential workers results in findings similar to those for healthcare personnel. Under maximized benefits, their work is essential for the response and overall functioning of society. In here too, there is a multiplier effect in that the ability of these workers to stay healthy helps to minimize disruption to society and the economy. Under justice, vaccination of workers helps address the elevated risk of exposure for those who are unable to work from home, and it also promotes access to vaccine in occupations with a history of low vaccine uptake. Health inequities have been documented for this group. Racial and ethnic minority groups are disproportionately represented in some sectors of essential workers, and almost 1/4 of essential workers live in low-income families. Next slide. For adults with high-risk medical conditions, vaccination would address the high burden of COVID-19 disease and the associated morbidity and mortality in this group. With respect to health inequities, an increased prevalence of some of the high-risk conditions has been observed for some racial ethnic minority groups and rural populations. While vaccination of this group could address these health inequities, some caution is indicated. Allocation of vaccine could increase health inequities because diagnosis of high-risk medical conditions requires access to health care in the first place, which is not uniform across this group. Hence, promotion of justice will require focused outreach to vaccinate persons in this group with limited or no access to health care. Next slide. And lastly, application of ethical principles to adults 65 years of age and older results in findings similar to those for persons with high-risk medical conditions. It would address the high burden of COVID-19 disease and associated morbidity and mortality for the group. With respect to health inequities, although racial and ethnic minorities in this group are underrepresented, they do have an increased rate of hospitalization. Caution is indicated here too, in that a strict age-based criterion could increase disparities due to various racial and social inequities, such as occupation, income, and access to health care. Under promotion of justice, focused outreach would be required to ensure that all persons in this group have an equal opportunity for vaccination. Next slide. Ethical principles and values can help steer and support difficult decisions around prioritization of scarce resources during a pandemic. Allocation of a limited supply of vaccine, however, is complicated by efforts to address multiple goals, most notably those goals to reduce morbidity and mortality and minimize disruption to society, the economy, and healthcare capacity, two of the goals for the U.S. COVID-19 vaccination program. If the goals of a vaccination program are not clearly prioritized, it becomes difficult to draw distinctions between groups for early phase allocation. As our walk through the table suggests, each of the four groups, from an ethical perspective, merits strong consideration for early allocation of COVID-19 vaccine. There is increasing consensus among COVID-19 allocation frameworks, as well as by ACIP, for early vaccination of healthcare personnel. This suggests that maintenance of healthcare capacity has emerged as the highest priority in the context of a severe pandemic. If vaccine supply remains constrained, it may be necessary to identify subsets of other groups for subsequent early phase allocation of COVID-19 vaccines. Such decisions at the national as well as local levels can be guided by the ethical principles and consideration of the key questions. It's important to bear in mind that the benefits of vaccine in the setting of a constrained supply, although delayed for some, will be available for everyone as supply increases. Next slide. Work related to the ethical principles is ongoing. Next steps include seeking ACIP's views on the updated principles and key questions, and publication of ACIP's ethical principles. In addition, further workgroup discussions about application of the ethical principles to help inform Phase 1 allocation recommendations is planned. So now we'd very much like to receive your input on the four principles. Next slide. And more specifically, how could application of these principles and key questions be made more useful to state, tribal, local, and territorial health authorities for COVID-19 vaccine allocation planning? So we would welcome your feedback at this time. Next slide. And I just want to close before the discussion to acknowledge Nancy McClung's work in progressing the principles and their application, the strong support and input we've received from our ethics consultant, Kathy Kinlaw, and our health equity expert, Dana Bowen Matthew, as well as continued assistance from Beth Bell and the entire ACIP workgroup team, all of which is very much appreciated.
Thank you for that presentation, Dr. Chamberlain. Comments? Dr. Hunter, please.
Thanks for this wonderful presentation. Lots to think about. I agree a lot with the principles. I'm struggling to maybe not how to apply them, but how they fit into the overall pandemic response. And when, the projections that we saw earlier show that it seems to matter less who gets the vaccine first, as far as, results on numbers of deaths and infections. Who gets it first, it seems to be less important than how soon the vaccine gets deployed and whether or not the vaccine prevents only severe disease rather than all infections. So, I'm asking for your help with me thinking about that from an ethical point of view. Does that matter? Or should we just keep a narrow view on we can do only what we should just focus on what we can have control over? I don't know. I need your help.
So it's a complicated calculus, you're right. And I think if we think back to the first slide in the presentation, that allocation, particularly in the early stages of a limited vaccine supply, is going to rest and be guided by not just ethical considerations, but by science and some of the implementation considerations that go along with this. And all of that will really need to be taken into account. And there will, I believe, Dr. Dooling's presentation is going to elaborate a bit more on this as well in terms of questions and recommendations that the ACIP will be asked to consider at the time that we have a vaccine available.
Yeah, thank you very much for bringing me back to your fundamental first slide. Yeah, that's the answer. Thank you.
Dr. Dooling would like to make comment.
I think Mary pointed to this, and you've picked up that, yes, the modeling work really measured one dimension of the impact of the allocation, and that was a version of cases and deaths. But really what Mary presented is a more holistic view that incorporates ethical principles as well as implementation, and those will need to be considered if vaccine is in short supply and needs to be allocated in early phases.
Thank you. Dr. Paling.
Thank you. Thank you, Dr. Chamberlain, for this fantastic presentation. And I wanted to thank you and the work group for thinking about the ethical principles. I'm going to agree with the revision to the updated four ethical principles, and I very much liked the action phrases. I also appreciate the questions, the key questions to help guide and try to integrate this into the process. I do need some more time to be thinking about those questions, and I appreciate all the work that you guys have been doing. Thank you.
Dr. Fry.
Thank you. And thank you for another great presentation today. I think a lot of people have been spending a lot of time talking about the considerations for allocation and the ethical principles and all the variations on the theme. What I think will go a long way, and I'm not sure how this can even be accomplished, is when we're talking about transparency, I think it will go a long way with the general public if we have a mechanism for reporting how product is actually being allocated and who actually is getting it. And this gets back to, I think, the trust factor of the general public, but also those who have for disparate populations or populations with disparities. And I was wondering if you could speak to that. Thank you.
This is Dr. Cohen. I can respond to that. That is something that we also agree is really important. How we report that out in terms of how much information we gather and at what level of detail we share without, imposing on states and other private types of data. We are still working out, but that is absolutely part of our overall plan to continue to inform the public about how the rollout of our program is working, along with many of the other things you've heard today about the safety and impact of the vaccine.
Thank you.
Dr. Atmar. Dr. Atmar, do you no longer wish to make a comment?
I'm sorry, I hit the wrong button again. I want to echo Dr. Paling's congratulations on a great presentation, and also endorse the modifications you've made to the plan for allocation. But I'd like to take a step back, and I'm not sure whether after your presentation is the right place to do it or maybe a little bit later, but not how to allocate, but whether to allocate, because one of the decisions ACIP will be faced with once a vaccine becomes available will be to review the data, look at the various groups for whom there are data, and to assess benefits versus risks. And, I'm personally have been struggling as I've thought about should a vaccine become available in the next month or two, that would likely be based upon efficacy data over a relatively short period of time, and safety information that over that same period of time didn't have any signals, but really without any information about long-term safety. So balancing the potential benefit of a use of a vaccine versus the unknown long-term safety issues that could arise, and in fact we've seen with other vaccines historically have occasionally arisen, and so I guess it has to do, part of the deliberation is on the scientific side, but part of my personal struggle is the ethical side, how to balance these two factors. And I think that's going to be a major issue that most of the members of the ACIP will have to struggle with. So I don't know whether you have any comments to help me along this path, or what kind of discussions have taken place up to this point.
So before I let Dr. Chamberlain comment, we will cover this issue in the upcoming talk. So if Dr. Chamberlain wishes to make any comments at all at this point.
No, I was actually going to reference the upcoming presentation as well, because as you indicate, there's a couple of really distinct questions that need to be teased apart here, and I believe it's Dr. Dooling will be covering this in her presentation. Thank you for those comments.
Thank you, Dr. Weiser, sorry.
Thank you. Thank you. This was a great presentation. I really appreciate it. As I'm looking at the slide on promoting transparency, this is really the gist of my earlier comment and the feedback we're hearing from tribes around the transparency and the communication and the time to provide timely feedback, and the dynamic tension that the compressed timeline creates to be able to honor that and respect that. So I just wanted to add that comment. Thank you.
Thank you. Are there any other comments or questions? Not seeing any, then let's move on to Dr. Oliver's presentation on workgroup interpretation of data.
Thank you and good afternoon. So I'll review the workgroup interpretation of data that's been presented today. Next slide. So to begin with the issue of prior infection, next slide. First, the workgroup emphasizes that we're awaiting data from the phase 3 trials for any possible vaccine-associated enhanced disease or reactogenicity after prior infection. No recommendations or vote will occur prior to data from the phase 3 trials. However, in the absence of concerning data from the phase 3 trials, the workgroup felt that an individual having a prior PCR positive, antigen positive, or antibody positive testing would not be a contraindication to receive a COVID-19 vaccine. The workgroup also felt that any vaccine recommendations that rely on knowledge of prior immunity or antibody testing would be quite difficult to implement. Next slide. Next, moving to the discussion around pregnant and breastfeeding women in the initial allocation phases, specifically phase 1A for COVID-19 vaccines. Most workgroup members agreed that breastfeeding would not be a contraindication to receive a COVID-19 vaccine. However, the workgroup acknowledges that this will need to be evaluated for each vaccine, especially if any live virus or live virus vector vaccines are authorized or licensed. Next slide. So next for the workgroup interpretation around pregnant women in Tier 1A. There are limited data on pregnancy expected from the phase 3 trials. Per published protocols, all trials are conducting pregnancy tests at screening and prior to the receipt of each vaccine dose, and are requiring women of childbearing age to use contraception during a specific time period before and after vaccination. While it is still anticipated that there could be pregnancies among trial participants, any initial information from the trial would likely only have follow-up for the first few months of pregnancy. The workgroup reviewed any available information on the vaccine platforms in pregnancy and the current epi among pregnant women that was presented earlier. While the workgroup did not reach a consensus, the majority felt that if a woman is recommended to receive the vaccine in an early allocation phase, pregnancy should be a precaution but not a contraindication to receive a COVID-19 vaccine. The discussions also emphasized the need to allow women to make an informed decision, providing all current knowledge of COVID-19 vaccines and platforms with pregnancy and the risk of disease. Next slide. The workgroup also discussed an additional situation that is likely to be faced when a pregnancy is diagnosed after the receipt of the first dose of COVID-19 vaccine, but before the second dose. The majority of the workgroup felt that the second dose could be given at the recommended interval, but there was a minority opinion that discussed postponing the second dose until either the second trimester or until after pregnancy. This was just based on a lack of data, not any specific concerning data. And again, the workgroup emphasized the need to allow women to make an informed decision. Next slide. Next, the workgroup interpretation of the modeling data. Next slide. So the workgroup felt that the differences among the three strategies presented, comparing different populations for phase 1B allocation, is minimal. Because of that, ethical principles and implementation considerations may greatly contribute to selecting the optimal sequence in phase 1B. The largest impact in averted deaths and infections is the timing of vaccine introduction in relation to increases in COVID-19 cases. This emphasizes the need to continue non-pharmaceutical interventions, such as wearing a mask and social distancing, while we await available vaccine. And finally, there are many factors that will ultimately inform the interpretation of the modeling data and allocation decisions, including the vaccine effectiveness in older adults, a vaccine's ability to prevent severe disease or transmission, and if the goal is to prevent the greatest number of infections or the greatest number of deaths. Next slide. And finally, to the clinical trial data. Next slide. We heard earlier from Novavax information on the immunogenicity and safety of NVX-CoV2373, their protein subunit COVID-19 vaccine candidate. Regarding immunogenicity data, neutralizing antibodies and binding antibodies were measured 14 days post-dose 2. Responses were similar to or exceeded convalescent sera comparison. In addition, there was a Th1 biased CD4 T-cell response. So based on their initial data, a 5 microgram dose adjuvanted with the matrix M1 was selected for the phase 3 clinical trials. Regarding safety, local and systemic symptoms were followed for 7 days post-vaccination. Headache, fatigue, and myalgia were the most common symptoms reported, but minimal fever was noted. Reactogenicity symptoms were higher after the second dose, and no vaccine-related serious adverse events were reported. Next slide. We also heard from Janssen regarding AD26 CoV2S, their non-replicating adenovirus vector vaccine candidate. Regarding immunogenicity, neutralizing antibodies and binding antibodies were measured 28 days post-dose 1. Responses were similar to human convalescent sera. CD4 and CD8 T-cell responses were demonstrated with the Th1 biased CD4 T-cell response. A single dose of 5 × 10⁻⁻⁻ viral particle was selected for the phase 3 clinical trials. Regarding safety, local and systemic symptoms were following after administration, and fatigue, headache, and pain were the most common. Reactogenicity symptoms appeared lower in the older population. Next slide. Both manufacturers discussed their plans for enrolling large phase 3 efficacy trials consisting of 30 to 60,000 people with the primary endpoint of symptomatic virologically confirmed disease, and are attempting to enroll diverse populations, including diversity among race and ethnicity, age, and underlying medical conditions. Next slide. While neither vaccine described today required ultra-cold chain storage, there were diverse cold chain and implementation requirements. The Novavax product is two doses given 21 days apart, with vials stored at 2 to 8 degrees Celsius. And the Janssen product is a single dose with vials stored at -20 long term, but can be at 2 to 8 for 3 months. Next slide. So the work group discussed that the phase 1-2 data from the vaccines show induction of binding and neutralizing antibodies, as well as T-cell responses, with a favorable safety and reactogenicity profile, supporting advances to phase 3 clinical trials. In addition, both platforms discussed today have some prior experience from other vaccines. And finally, the work group discussed that safety pauses are expected with large clinical trials and indicate that the process is working appropriately. Next slide. Regarding all phase 3 clinical trials, the work group again emphasizes the importance of enrolling diverse study participants. There have also been discussions around the importance of harmonizing safety and efficacy endpoints across phase 3 trials to the extent possible. Given the discussions around pregnant women earlier, the work group also discussed the need to report maternal and fetal outcomes for women who become pregnant during the clinical trials. And the work group supports FDA's guidance for ensuring that phase 3 trials conduct ongoing assessment of long-term safety and efficacy, and that issuance of an EUA alone is not grounds to unblind follow-up in an ongoing clinical trial. Next slide. So thanks, and we'd be happy to take any questions. And in addition, we'd love to hear input from the ACIP members around these specific issues.
Before we do so, I understand that Drs. Eckert and Maldonado have comments or statements to make from their respective organizations, that is ACOG and AAP. So does Dr. Eckert wish to go forward?
Yes, hi. I read our full statement at the end of the last talk, so I'll just reiterate on the behalf of ACOG that ACOG urges ACIP to incorporate pregnant and lactating women clearly and explicitly the COVID-19 vaccine action and prioritization framework, and should an EUA be executed for one or more COVID vaccines, and provide a permissive recommendation for pregnant and lactating women, pregnant healthcare workers, pregnant first responders, and pregnant individuals with underlying conditions should be prioritized for vaccination alongside their non-pregnant peers. Thank you.
Thank you. Dr. Maldonado?
Yeah, thank you. So we have not been able to, we have not had time to approve any formal statements from the Academy, but the Committee on Infectious Disease Leadership of the Academy does not have any significant concerns specifically about breastfeeding after receiving COVID-19 vaccines based on the current data, but we do agree with ACOG's statements and defer to them regarding issues around pregnancy and pregnant women. We also would like to emphasize, again, the need to move to pediatric trials when the data suggests that it is safe to do so. And we agree with the following up of maternal and fetal outcomes post-licensure, during trials and post-licensure as well. And we'd be happy to discuss further issues around MISC definitions in the post-vaccination licensure monitoring as well. Thank you so much.
Thank you. I see that Dr. Atmar has a comment. Please, Dr. Atmar.
Thank you. I have a comment related to the unblinding of the clinical trial should an EUA become available. And particularly for those study participants in the vaccine trial where efficacy and safety are demonstrated. As a clinical trialist, it bothers me that the participants in the trial won't potentially have the benefit of receiving the vaccine once efficacy is demonstrated. These volunteers have assumed the risk of study participation. And in most clinical trial circumstances, once the main question of efficacy has been demonstrated, would be among the first to potentially benefit. I understand the conflict and the issue I raised a few minutes ago about follow-up and long-term safety questions, but I'm bothered about the burden that these individuals have taken on to help us identify an effective vaccine and not be allowed to benefit unless they happen to be in one of the early category groups that will be prioritized for vaccination and have to drop out to get vaccinated. Over.
Thank you for those comments. And I think many in the group echo them. I think that's an issue, though, that fortunately we can't deal with because it's going to be an issue more that VRBPAC and FDA will have to address. But thank you for bringing it forward, and hopefully they are listening to us. Dr. Sanchez.
I just want to agree with Dr. Atmar as well, especially if they're in the high-risk groups. But another comment I want to also echo ACOG and the pediatric ID. I think that pregnant women, that it needs to be available for them, and also in terms of the lactation, I would strongly urge not to. I think I would be positive because we shouldn't bring consternation in women who are breastfeeding not to take the vaccine because it's not known. I think we need to be positive because the likelihood of anything being transmitted from a vaccine through the breast milk is so minuscule that we have to take it as a positive approach rather than one that we may not know.
Thank you. Mr. Nally.
To follow up on the discussions the work group had regarding pregnancy, and there was a note there that it would be important for the women to make an informed decision. So can you just kind of expand on how you anticipate that informed decision-making process to occur? And I think that it's also relevant to the breastfeeding question as well.
Yeah, thanks for that. This is Sarah. So in addition to, engaging with ACOG and AAP around these issues, we hope to engage further around issues of education and how we can work with our colleagues who have kind of expertise in this area to come up with educational materials where we make sure that all of the information that is currently known, we said both around the platforms as well as kind of the epi and risk of pregnancy, that be made available at the time of vaccination. So we're working on kind of exactly what that would look like and around educational materials, but those discussions are ongoing right now.
Thank you. Dr. Hunter.
Yes, I just wanted to say that as a ACIP member who's not on the work group, I just wanted to let everybody know that I agree with the majority views of the work group regarding the prior infection, pregnancy, and breastfeeding, just so you know. Thanks.
Thank you. Ms. Bata.
Yes, thank you. I have a question in relation to pregnancy and maybe inadvertent vaccination when someone's pregnant. is there plans for a registry?
Hello, this is Titiloco Diego. Can anyone hear me? Yes, thank you. Titi Odeo from CDC. So in terms of with pregnancy that inadvertently vaccinated or exposed, so definitely in the clinical trials, the manufacturers are supposed to have a registry and to follow this women. In the post EUA, when a vaccine gets an EUA, CDC, as Dr. Shimabukuro had mentioned, with using the traditional platforms as well as the innovative platform like the VSafe, where women who get vaccinated, if they do opt in, when the text that goes out to them, they will be asked in terms of if they were pregnant when they got vaccinated, and then the follow check-ins, they will be asked if they had a positive.
Dr. Oduewu, just one moment, please. Dr. Cohen has something to say, please.
Oh, no, apologies. I just wanted to make sure everybody knew who it was who was speaking, that this is Dr. Duebo with CDC. Sorry.
Continue on with your discussion.
Okay, thank you. And that so in terms of with the check-ins with VSafe, they would also be asked in the check-ins if they've had a positive home or laboratory test so that we can identify this women. And then with CDC, there's ongoing discussion of how this will happen, but the plan will be active surveillance of this pregnancy so that we can get that information and share that over.
Thank you for that answer. Are there any other comments or questions from the liaisons or the voting members? I don't see any, so let's go to our final presentation of the day by Dr. Dooling. Policy questions, evidence to recommendation framework, and discussion.
Thank you, and good afternoon, everyone. First, I'd like to thank all the speakers today who have provided us with the most up-to-date information on COVID-19 vaccines. Information ranging from vaccine development to safety monitoring, implementation, ethical allocation of vaccine and modeling, and disease epidemiology. And second, I'd like to thank you for your long attention span. This is the last presentation of the day, and we aim to gain ACIP feedback on the vaccine policy questions that lay ahead. And to do that, we'll review the work group conceptualization of those policy questions and how the evidence will be presented for ACIP consideration. Next slide. The work group started with these goals, and they continue to kind of be our North Star. Once again, I'd like to ground the conversation in those. First, to ensure that we have a safe and effective vaccine, that vaccines reduce the transmission, morbidity, and mortality of COVID-19 disease, that the vaccine program helps minimize disruption to society and the economy, including maintaining healthcare capacity, and that we ensure equity in vaccine allocation and distribution. Next slide. This slide depicts at a very high level the ACIP path to a COVID-19 vaccine recommendation. Following an FDA decision, be that full licensure or emergency use authorization or expanded access, the ACIP will face two policy questions. First, should the particular COVID-19 vaccine under consideration be recommended? This policy question will undergo the standard, rigorous, and transparent evaluation of the evidence to recommendation framework and the grading of the vaccine. This evidence will be presented to the ACIP for deliberation of the policy question and a potential motion to vote on a recommendation. The second policy question is, to whom should early allocation of COVID-19 vaccine vaccine A be recommended? This question will be addressed through scientific evidence, ethical principles, which you heard about earlier today from Dr. Chamberlain, and the implementation considerations. Again, the evidence will be presented to the ACIP for deliberation of the policy question and a potential motion to vote on a recommendation. Next slide. So let's take a closer look at the two policy questions proposed by the work group. First, should COVID-19 vaccine A be recommended for adults in the US? Second, who should be recommended to receive COVID-19 vaccine A during phase 1. Recall that the ACIP has already expressed support for inclusion of healthcare personnel in phase 1A. Additional groups discussed for inclusion in phase 1B are essential workers, non-healthcare, adults with high-risk conditions, and adults 65 years and older. Next slide. The evidence to recommendation framework was first endorsed by ACIP in 2018 and has served as a tool for standardization and transparency in vaccine policy decisions. The work group will review the evidence in each of the following domains. Is the problem of public health importance? The balance of benefits and harms, the values of the target population, acceptability to key stakeholders, feasibility of implementation, resource use, and equity. Next slide. The COVID-19 pandemic has resulted in a disproportionate disease burden in certain groups. That's not a surprise to anybody listening now. Persons who are African American, Hispanic, American Indian, or Alaskan Native have experienced higher incidence of disease and death compared to non-minority persons of a similar age. And the mortality in older adults has far exceeded that of younger people. Much of the work group discussions has focused on equitable vaccine policy. This was first articulated in the vaccine program goals, is featured in the ethical principles for allocation of early doses that you heard about earlier, and has now been included as a domain in the evidence to recommendation framework. Next slide. Back one. The central question of the equity domain is, what would be the impact of a vaccine recommendation on health equity? And to unpack that, there's a series of sub-questions. Are there any groups or settings that might be disadvantaged in relation to the problem or the options that are considered? Are there plausible reasons for anticipating differences in the relative effectiveness of the vaccine for disadvantaged groups or settings? Are there different baseline conditions across groups or settings that affect the effectiveness of vaccine or the importance of the problem for disadvantaged groups or settings? And finally, are there important considerations that should be made when implementing the vaccine in order to ensure that inequities are reduced whenever possible and to make sure that they are not increased? Next slide. The work group proposed the following PICO question for policy question number 1, and it breaks down as follows. Population, adults. The intervention is the specific COVID vaccine under consideration. The ultimate comparison group is to no COVID-19 vaccination. In studies, this might take the form of a placebo arm or a non-COVID vaccine. And finally, the outcomes. The work group felt that the critical benefits of a COVID-19 vaccine included the potential prevention of symptomatic PCR-confirmed disease and hospitalization due to COVID-19. The harmful outcome most critical to assess is the potential risk of serious adverse events following immunization. The proposed important outcomes are all-cause death, as well as SARS-CoV-2 seroconversion to a non-spike protein and serial PCRs, both to assess for asymptomatic infection. The work group also proposes to assess the outcome of reactogenicity. Next slide. As you can see, most of these outcomes are being assessed in clinical trials, with the exception of serial PCR tests for asymptomatic infection. The work group felt that understanding any vaccine's ability to prevent asymptomatic infection and prevent transmission is important. The work group encourages COVID-19 vaccine candidate sponsors to strongly consider inclusion of this outcome in clinical trials. Next slide. In summary, here are the next steps for the work group organized by these 2 policy questions. For policy question number 1, the vaccine recommendation question, the work group intends to populate and review the evidence to recommendation framework, start grading vaccine evidence and incorporating phase 3 data when it becomes available, and discuss clinical guidance such as special populations, concomitant administration with other vaccines, and vaccine scheduling issues. For policy question number 2, the allocation question, the work group intends to publish the ethical principles manuscript and to incorporate the latest information regarding science, implementation, and ethics to further refine phase 1 allocation. Next slide. So in conclusion, during ACIP discussions, the work group would like to hear if ACIP members agree with the proposed policy questions and outcomes. Thank you very much, and I will return the floor to Dr. Romero.
Thank you. So are there any comments or questions from the work group? I'm sorry, from the voting members or the liaisons? Dr. Paling.
Dr. Dooling, thank you for a great presentation and for the work group that has put all this information together. I do agree with the 2 questions that you have, and I do like that the 2 will be answered separately. I also very much appreciate the discussion about the outcomes and the serial PCR for asymptomatic infection. I would like to also highlight a comment that's been made earlier about maintaining longer term follow-up for beyond 2 months for people who've been vaccinated. So thank you.
Thank you. Dr. Hunter.
Yeah, I think that the structure of the 2 policy types of questions is very good. I'm struggling with this unprecedented situation where we might need to consider some type of conditional recommendations. I don't know, maybe that would allow some vaccine out for folks that are at really, really high risk who are willing to, or on that continuum of, demanding vaccines or refusing vaccines, are more on the demanding side. And so sort of that combination, if there's ways we could get vaccines out to them very early, maybe earlier than we might feel comfortable with otherwise, and instead of necessarily, and somehow incorporate principles of informed consent, sort of a higher level of clinical decision making, up to the level of informed consent. I guess that's the reason I'm struggling with that, is combining that with trying to get vaccine out as fast as we can, at least to people who really, really want it and are really willing to take on a little bit of risk. So I just wanted to get that struggle out there and have people think about it, and whether or not that's even an option to consider as, being a very nuanced, sort of aggressive way to get vaccine. And I wouldn't say aggressive, sort of a limited way of getting vaccine out as soon as we can to sort of react to that modeling that says the faster we get some vaccine out, the more death and infections we're going to prevent. I don't know if I'm making sense, but I just wanted to get that struggle out.
You are, and it will be taken into consideration and discussion. Dr. Atmore.
Thank you. And I thank you for the presentation. I agree in principle with the PICO questions and the way you have this set up. What troubles me is that as set up, to echo what I said earlier and Dr. Paling alluded to a few minutes ago, this doesn't really take into consideration any time-based either protection or safety, other than the data that will be provided should an EUA come through in a relatively short period of time. If we don't see something like this until 6 months from now, it's less of an issue. But if we see something next month or in December, then it becomes much more of a problem. And the problem is that what I'm bothered by is the unknown, not the information that will be presented to us, and how to incorporate that or balance that with the information, the objective information that will be available. And one can look at the objective information and arrive at one conclusion to go ahead and move forward with allocation. But that presumes that there's not going to be some later problem. And what we found out about this virus so far is that it's unlike really anything we've seen before. And so the unknown is and bad possibilities are always a consideration. So I don't think I have a solution for how to handle the time-based question, but there may be members of the work group that have better ideas about how to handle this than me. Over.
Thank you. Dr. Fry.
Thank you. I also would like to bounce off a little bit of what Dr. Atmar said. I struggle with following people for a mean of 2 months after their second vaccination as a time point to start making decisions about, final decisions about safety. I guess I just want to put that out there. And there's also, on the basis of everything that we've talked about and what we know about reinfections and everything, there is a possibility that this might need to be, if you will, I don't like to say this out loud, but could be something that we need to administer on an annual basis. We don't know that yet, but that's a slightly different question, of course. But I do like the two questions that were proposed. I think that's a great starting point. I'm just concerned about quick decisions on safety. Thank you.
Thank you very much. Dr. Bell.
Yes, I wanted to say that I appreciate this discussion and the points that the ACIP members have been raising about, especially around this issue of 2 months of safety follow-up and the FDA guidance. And I know Dr. Fink is listening and presumably is hearing concerns of some of the ACIP members about what is a minimum that the FDA has established. One question that I wanted to raise for some feedback related to this topic is that what we're talking about here are balancing potential benefits and potential harms. And what Dr. Atmar is saying is there may be potential harms that we don't know about now. And in that context, you'll note that that the work group has considered as objectives. We've lumped together mortality, morbidity, and preventing spread for the most part. And I'm just wondering about people's reactions to the idea that perhaps in the context of unknowns, should we be thinking more carefully about, for example, focusing early allocation preferentially on preventing mortality, or should we in some ways try to disaggregate those because of the unknowns, especially in the harms section of the calculus?
Thank you. Dr. Dorn, if you're still listening, and sorry, Dr. Fink, if you're still listening and want to offer comment about the period of time that that being followed for the vaccine, the 2-month median period, I think you had covered this at the VRPAC and made some comments there.
Yeah, hi, I can address that. So what we said at the VRPAC a little over a week ago is that we really are trying to strike a balance between what's reasonable and what's necessary and what might give a hope of impacting the pandemic in a beneficial way. I think you heard me discuss some of the reasoning behind arriving at this 2-month median follow-up in terms of what we know from our historical experience with preventive vaccines and the types of adverse events or adverse reactions that that have been associated with vaccines over that time frame. The question, really becomes what additional return or what additional assurance could we get from a longer period of follow-up, especially without looking for more uncommon adverse events in a much larger database of vaccine recipients, which is really what might be necessary in order to address some of these unknowns and determine whether there are risks that are unknown at the time of vaccine deployment. So all of these considerations went into how we constructed our expectations for emergency use authorization. Over.
Thank you very much. Dr. Szilagyi.
Yes, I actually had very similar comments to what was stated before, so I won't belabor that. I was just kind of thinking about the concept of flexibility, both over time, and this doesn't have to, I agree with the two policy questions. I think it fits PICO perfectly. But with some statements that there may be alterations, modifications down the road as time goes by. Flexibility in two ways. One is over time, the way we were just discussing, and the other is flexibility in the implementation. So for example, and I know this isn't part of the recommendation, but it's more in the implementation, but local areas are going to have to deal with the reality of, do you save doses for the second dose versus giving to newer populations or very high risk populations, the way Dr. Hunter spoke about. Overall, though, I think this is the right policy question for us to discuss.
Thank you. Dr. Paling.
I want to say thank you for these comments. I think it is really important, and we are all saw from the modeling that getting the vaccine in earlier has additional benefits, and then the uncertainty is what we're really weighing. And I guess one thought is the way it was presented said there was an ACIP recommendation. And is there, perhaps we could think about reviewing data on a monthly basis and updating the recommendation so that we can account for the concerns and balance both the benefits and the harms. Over, thank you.
Dr. Dooling wishes to make a comment.
Thank you for that. And you bring up an excellent point that these recommendations, both for the vaccine recommendation and allocation, will be revisited in what is a very dynamic situation. So all new evidence will be brought to ACIP, and certainly the allocation as vaccine distribution proceeds will need to be adjusted accordingly.
Thank you. Dr. Lee.
Thanks so much. And I agree with the dynamic decision-making process. I mean, I think that has to be exactly what we have to just plan to do. With regard to where I think I'm struggling is, we're very focused on safety, which is incredibly important. But I guess my concern is around understanding the durability of the immune response. So if we have 2 months of follow-up for half the participants. On the safety front, it is true that most of the adverse events of interest are going to be captured within the first 6 weeks for sort of the real-time things that we can monitor. And then there will need to be long-term safety studies for other adverse events. The one adverse event I guess I worry about is vaccine-enhanced disease, because that is one that I think is going to be very difficult to not capture, but rather to evaluate in observational data. And I do think the clinical trial data will be superior for that type of an adverse event. Of course, we don't know how long it'll take to evaluate that. And on the other hand, we have significant burden of disease. The disease rates are disease incidence climbing, and we continue to have many, many deaths, every week in the U.S. So weighing that against the idea that we also would only have about 2 months of efficacy data. And I'm feeling, like there's a fairly good chance that we're going to be okay on efficacy in the first 3 months post-vaccine. I guess my question would be understanding what it looks like beyond that, since we're still learning much about natural immunity, and we'll be learning in real time about the durability of vaccine-mediated immunity. So in thinking about that, wanted to just say that, assuming that there are no significant safety concerns after the first 2 months, that may be fine, but it's under the assumption that the efficacy will be durable and go beyond 2 months. And that's where I get worried that the benefit risk balance is not clear to me. So I'm wondering about, whether or not all trial participants could have 2 months of follow-up data, because that means the first half of those trial participants might have 4 to 5 months where we could actually assess the durability of protection or, persistence of neutralizing antibody or Th1 responses that go beyond the first few months. And that would then give me more confidence, not necessarily because the safety data has changed, but because we know that the benefits will be beyond the first couple of months of vaccine.
Thank you. Ms. Bata.
Thank you. One of the issues that I really like these questions. I think they are very helpful. I think they're clear. I would just stress the importance of the discussion of feasibility in the context of the allocation recommendation, equity piece of this. And just stress the ethical principles, a manuscript that you're working on is going to be extremely important to local jurisdictions because we need that concrete guidance in terms of, again, equity and a sense of fairness in how allocation gets implemented. Thank you.
Thank you. Ms. McDowell.
I just wanted to lend my support to Dr. Paling's comments regarding monthly or frequent data review and tell Dr. Dooling that I was very happy to hear her response to that. I want to note, though, that I think that the messaging of that information will be very important to public confidence on this vaccine.
Thank you. Are there any other comments from the voting members or the liaisons? I don't see any. So with that then, I think we've drawn to a close for this meeting, exceptionally long. Thank you all for participating throughout the 3 days of this October meeting. And more so, thank you for maintaining stamina and continuing to participate actively and contributing to our discussions regarding the work on COVID disease vaccines. So thank you very much. We will see each other at least in February, from what I understand, and we may have another, or at least hear each other in February, because it sounds like it's going to be virtual, and possibly before that in an emergency meeting. Thank you all, and take care of yourselves and rest. This is a marathon, not a sprint. Gaveling closed.